You have anything else you wanted to add, Randy?
No. I was just saying, how you doing? Let's go. Good
Doing
to see
good.
you.
Okay. So I actually had heard of Stacey just in the Northwell stratosphere. I've been here since around 2010. I was at North Shore Hospital, and Dr. Rosen was a well-known cardiologist at LI Long Island Jewish, which is one of the group of hospitals in Northwell, and she has risen to be a real leader in women's health, cardiovascular disease, and when I was talking to her about this course, just the preponderance of the supermajority of women who are in the course. Cardiology is a field that's lacking. It's really still a very male dominated, like neurosurgery. And so having women leaders, and for men should understand this too. It's important that men have strong women leaders. I've had great mentors who are women, in some ways more than men. And so hearing her journey, she went to medical school at BU, trained at Montefiore, and then went to Cornell for her cardiology fellowship. And she also did extra time in echocardiography, which is looking at the heart with ultrasound. And then she rose up the ranks. Most recently, she was named, I think, Doctor of the Year for the American Heart Association. So we're really looking forward to hearing what you have to say about your career journey, reflecting on maybe some failures in your life and things, inflection points for this group, and hopefully turn some of these 1,000 or so participants into cardiologists, which my dad was a cardiologist, so I'm, partial to cardiology. So with that, I'll let you take it away.
Thanks, David. Thank you so much. When it comes to merch, I think I should be buying you a gift for including me, because this is surely going to be the best hour of my week, which says a lot, don't you think? So today I thought I would, spend a little time telling you about myself. The good, the bad, the ugly. I am not somebody who was born strategic, and I have a lot of big titles, but a lot of it had to do with luck and hard work and meeting the right people. And we'll talk a little about that. I want to speak a little bit about what women's health is and what it's not. It's not girl doctors, for instance, and it's not just boobs and tubes, as one of my colleagues at Brown says, what was more politely called the bikini approach to women's health. I want to walk you on a little bit of a journey through women and heart disease and how that is the sort of quintessential story for why women are different than men, if you didn't already know that. And lastly, a little bit about getting where you want to be and what it's like being in a field that doesn't have a lot of women. I think, David, we're about 14%. I mean, I graduated fellowship 30 years ago this year, and I think women were 11% when I finished. So, we're doing equivalently badly to some of the, important surgical fields that don't have enough women. So, we have a lot of work to do internally and externally. So I think, Ashley, are you running my slides, or do you want me to? What's easier?
If you're able to share your screen, then you should be able to do that. I think it'll be easier that way, because otherwise you'd have to keep telling me like, next slide, next slide, next slide.
Yeah, you got it. Give me 1 second, share screen. Are we good? I'm on several monitors.
Looks good. Looks good.
You're seeing my slides?
Yeah, see fat and skinny, yeah.
Nope. All right, we'll go to that. So firstly, as I said, I'm a New Yorker, oldest daughter of 2 educators who drove from a nice, predominantly white suburb on Long Island to the 2 poorest school districts in Brooklyn, actually, and were teachers and principals and superintendents their whole life. And I sort of grew up in a house with no doctors, but with a sense of fairness and equity and social responsibility. I thought medicine looked quite interesting when I was in high school, because it seems like a role in which I would never be bored, honestly. I volunteered at local hospitals and a memorial, and I saw that doctors could teach, could see patients, could educate, could advocate. It just seemed like, the perfect opportunity to just evolve over a lifetime. I foolishly thought, I went to a 6-year medical program, which I don't even think they exist anymore. They're 7 or 8 years, but I went straight to high school, to 2 years of college at BU, and then straight to BU medical school. I have a daughter who is a medical resident, and I virtually forbade her to do that. I think that, the ability to screw up in art history and take English classes and painting was wonderful. And we were, a guaranteed introduction into acceptance to med school. But at the other hand, college is wonderful. So I have 3 kids finished college, and not one physician, and nobody. I mean, we don't not allow our kids, as but we certainly didn't let it happen. Cardiology seemed like the most exciting field to me. I joke about it being really simple. It's a big pump. The physiology made sense for me. In career decisions, the only decision for me was deciding between pediatric cardiology and adult cardiology. And I remember going to the head of pediatrics at Boston City Hospital, and he said to me, "Well, do you like kids, Stacey?" And I thought, "Ooh, I was like 22 years old. I kind of hope so." But when he put it like that, I thought probably not enough. So I went the adult cardiology route, and I trained in internal medicine. I was a chief resident. I only applied to city hospitals because, to me, that's where the excitement was in the 1980s, late 80s. I felt there would be more independence. I felt that it was a place for me to participate in health equity before we called it that, social determinants of health before we called it that. And I was a chief resident at Montefiore, and thought that the excitement was in the cardiac cath lab. So matched at New York Hospital. And for me, just interestingly, I was the city hospital kid. I never wore a white coat to work. So when I got to New York Hospital, as the only female fellow, honestly, and called the GF, Girl Fellow, how frankly lovely, and had to put on a white coat for the first time. And I got into the cath lab, and for Dr. Langer and my neurosurgery friends, you either walk into a procedural space and you're in heaven, or you walk into a procedural space and think, yeah, I don't really like it here. So I walked into the cath lab and thought, oh, this is as good as it gets. I don't like it. And echocardiography at the time was advancing skills to do not just anatomy, but physiology and impact. And so I did my advanced training in echocardiography. Worked for a couple of years at Mount Sinai, and then was recruited to North Shore Hospital in, I guess, almost 1995, the very tail end of 94. And I've been here ever since. My clinical roles, I ran the echo lab at North Shore Manhasset. When North Shore University Hospital and Long Island Jewish Medical Center merged, I was a refugee sent from North Shore to LIJ to be the chief of cardiology. I was way too young and inexperienced for the role, but it taught me a lot about bravery and hard work and resilience and failing really badly. To be quite honest, after about 18 months of that, I almost quit, thought I was doing my family a favor, and my chairman forbid that from happening. And, in retrospect, some of the failures you make are the best things. They teach you new skills. They allow you to see the importance of what you're doing. I ran cardiology at LIJ Medical Center for about 13, 14 years. I also ran our fellowship program. My late father, the school superintendent, would have been really proud of that. He always taught me that anyone could teach the easy students, and, being a good medical educator is hard, and that's the fun of it. My clinical work and my research was always on the inequities of cardiovascular health for women. And so Northwell, and I'll tell you a little bit about our CATS Institute in a minute and tell you why, but 9 years ago, I pivoted to oversee the CATS Institute. And I'll tell you a little bit more about it when we bring up the slides. And I'm now the senior vice president. I still practice cardiology. It is the day job that I will never give up. I am 59 years old, and when I retire, when I'm 1,000, I will practice full time. So, as Dr. Langer, as a chair, knows, part of the struggle as we have administrative and management and teaching expectations is staying true to what you love. And for me, it's never giving up clinical medicine. I think it makes us better leaders. I think it is the joy in my career. I mean, I've been an AHA volunteer forever. So to get the Physician of the Year award, you have to be a practicing doctor. And of all the things that the AHA does, that is the accolade that I would have most, been thrilled to have. So let me talk to you a little bit about you. You're seeing my slides, correct? Yes. Yes, good. Okay. So this is, thanks, Dave. So this is what women's health is. As I said, women is not female doctors. It's disparities in the way we practice medicine. It's the disparities in the way we research diseases. We've studied fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anybody. And this is sort of not a joke. Historically, even when us oldies on the phone were in training, all the research, all of the science was done on men. The assumption was that women were the same, except for pesky hormones and the bikini organs, and that whatever worked for men, it would be so much easier to study them. We would just extrapolate for women. And it made perfect sense. It was certainly not something that we did, seeking to do harm. But we all know men and women are different. For those of you men and women on the phone, we also know that men and women communicate. I have 28-year-old boy-girl twins. The female is the doc, the son is a finance guy. And this is, the difference in sex and gender is I had a control group in my house raising these two. So this is how it started. Hygeia is the daughter of Asclepius. She is the goddess of health. He is the god of medicine. He had 5 daughters. One of the other 4 was named Panacea. You all know what that is. And she was in charge of cleanliness and prevention. And the snake that she's holding is the caduceus, right? And you've all seen that on it's even on our Zucker School of Medicine logo. So this goes way back. Nanette Wenger is a 90-year-old practicing cardiologist at Emory. She is legendary in our field, not just as a woman cardiologist, but as the originator of women's cardiology as a special field, preventive cardiology. And she's the first one, along with Bernadine Healy, who's the first woman to run the NIH, who used the term bikini medicine. And we felt that women just breast and reproductive systems, and that was the only difference. And it cost us pretty badly. In fact, for any of you who has participated in basic science work using labs, historically, even the rats used were male. In fact, they were cheaper because the scientists and investigators never had to manage changes in hormonal status. But the truth is, those pesky hormones have a difference anatomically, physiologically, impact of medications, et cetera. So they're not just confounders, they are actually things that, so Mickey and Minnie, it was always Mickey and, no Minnies. Paula Johnson ran the Women's Institute at the Brigham, and she is now the president of Wellesley College. And Paula is one of the founders of this as well. And, it doesn't take a medical degree to know that men and women are different, but sex-specific research just never happened. Dr. Johnson, too, is a practicing cardiologist, and the damage done by assuming the male model into women was terrible. And I'll show you that in a moment. Just quickly, sex and gender are not the same things. Sex is biology. It's the cells you're born with, your chromosomes. Gender is really the position, the self-identity, the social representations. And both of them have an impact on healthcare, medicine, wellness, etc. So this is sort of a fun slide that shows the difference between gender and sex. I love that the gender, I'm a shoe fiend, that the gender part on your left, I guess, has a high heel and small shoes, whereas sex is our genetics, it's the cellular. And the important thing to remember, and we screwed up in the past because we didn't appreciate that every cell in your body has a sex. And every cell in your body behaves differently because of it, not just, boobs and tubes. So, when it comes to gender, how women approach life, this is sort of a little spoofy, borrowed from my friend, Dr. Jean Cacciabato, but women take care of everybody before they take care of others. And in my field, in stroke medicine, in cancer prevention, in so many other areas, the women's lack of prioritizing their selves has become a problem. I don't have pets, but I do have a 33-year-long husband. And I think it's pretty funny that pets is above husbands, but I'll leave that to the pet owners. So it wasn't just the cardiac world that saw this was a problem. The Institute of Medicine, now known as the National Academy of Medicine, put out a really important monograph in 2001, Does Sex Matter? Haha, the answer of course is yes. And it showed that the science of how we created medicines and procedures and studied diseases and wellness was particularly poorly done, because we really didn't put what is now called sex as a biological variable. And at the end of this, the call to action from this IOM monograph was, we need to do better. We need to look at different areas, see where we do well, and put together more of a structural and strategic approach to this. So about a decade later, this second monograph came out of what was then the IOM and confirmed that in every area, neurosciences, cardiac, cancer, HIV, we were making so many strides, behavioral health, we had neglected the needs of women. There were disparities in disease, even among certain segments of women. And even if we included women in studies, and we do in hypertension and some other aspects of cardiac disease, we don't present the data independently. And the truth is that harms women and men, because if we over or under represent a finding based on sex or gender, we do disservices to everybody. So the IOM and the NIH and Health and Human Services from the federal government defined an expanded view of what women's health is. And women's health are either conditions where women are uniquely affected, mostly gynecologic, obstetrics, of course, conditions where women are affected disproportionately. So for those med students on, depression is very much more common, you'll see in your clinical work in women. Gallstone disease is completely different. Osteoporosis is completely different. And then there are conditions where the manifestations in women are different. Autoimmune diseases are 80 to 90% women, things like rheumatoid arthritis and lupus, and we still don't know why, and we need to ask those questions. Heart disease is completely different in men and women, even lung cancer. Women who don't smoke are 10 times more likely to die from lung cancer than men who don't smoke. And looking at that finding and then diving deeper is the only way we're going to learn about why that is. Is it the pesky hormones? Is it something physiologic? Is it something about the way women obtain healthcare? So the Katz Institute for Women's Health actually was launched about a dozen years ago, and it was the dream of a pair of important philanthropists in our community who felt that women's health was being neglected. And the background story, Saul and Iris are a phenomenal couple. When Iris and Saul went to their internist about 25 years ago, the internist, who they share, turned to Mr. Katz and said, Saul, you should be taking a baby aspirin a day. We have this terrific data that shows it prevents a first heart attack or stroke. And Mrs. Katz turned and said, what about me? And the internist honestly said, yeah, we don't really know about you, Iris. I guess take an aspirin. And that's how I practiced for the first 15 years of my clinical career. We just assumed that if it worked for men, it would work for women. And then we found that that wasn't the case when we actually did the study on a similar number of women, and we found that the benefit wasn't the same. And so she felt that this was not fair. And so her vision was to really put women at the center of everything we do and focus on sort of a new approach to healthcare. So the Katz Institute for Women's Health exists throughout Northwell. And as you know from Dr. Langer and our team, that we are an enormous health system, with a spectacular medical school and nursing schools. We have extraordinary research, but we're also a group that is sort of innovative and collaborative. We're fearless, I would have to say. So the Katz Institute focuses on 4 pillars. And this was borrowed from Health and Human Services and the NIH in the 1990s when centers of excellence for women were defined. And these are our focuses: clinical programs that focus on true sex as a biologic variable and expertise. Community partnerships. The public health world has taught us that only 20% of your ability to stay healthy over a lifetime happens in a doctor's office or in an emergency room or in an OR. And how you live, how you're educated has an enormous. So being out in our community and partnering with women. Kaiser Permanente did a neat study a bunch of years ago and showed that 80 to 90% of a family's healthcare decisions are made by the women. So in CATS, we hope to own the women and make them smarter partners for us, because we know that impacts on families and communities. Research, as Dr. Johnson reminds us, if you don't ask the question, you don't look at the observation, you don't study it, you don't get the answers. And then finally, education, and that's both professional. We do a lot of interdisciplinary education amongst ourselves, as well as to our community. So if you imagine, I'm an internist cardiologist, right? But other internist specialists include HIV doctors, gastrointestinal doctors. I don't really have as much to do with them as I do with stroke neurologists and stroke interventional radiologists. So if you imagine, even though our board certification and the way we studied had us in silos, we've developed over, mine and Dr. Langer's careers, the appreciation that working out of our silos and putting the patient in the center of what we do is really a better way to work. So in my world, women's institutes include these kinds of collaborations. In my cardiac day job, cardiovascular neuroscience institutes are really my partners, as opposed to those that have necessarily the same board certification that I do. We grow clinical programs. I just spent quite an interesting talk on some of the neuroscience leadership. Things like migraines, things like stroke are different in women. There are tumors that are different in women, movement disorders that are different in women. So we work in partnership with clinical leads, chairman, leaders, to figure out where the sweet spots are with women's health programs. We do a tremendous amount of community education. There's a really cool, I'll share with Ashley, with you, our newsletters that come out. We do an enormous amount of now digitally based community education that are evergreens on our websites. What's kind of fun about being in our new digital world is that we have people signing in from Eastern Europe, from Canada. We've got a woman from Toronto's on our baby basics course. I mean, it's really kind of fun to be out there. We did a program for a group of tech giants in California a few weeks ago. So we're never going back to sitting in small conference rooms. It was like we can be together like this. The research we fund, and we also support for grant writing. We have a cool grant program. I think we'll hit $1 million this year in our 5th year. And these are small seed grants for unique and interesting collaborative projects. And what's kind of neat for any of you who've worked in research is that sometimes it's hard to get that starting funds for a small project that then allows you to continue. So one of our favorite stories is a group at Feinstein, our research institute, that was working on endometriosis, which is a abnormality of women's uterine tissue that causes terrible menstrual periods and infertility. And historically, women were told, young teenagers and young adults, to sort of suck it up, excuse me, that, it's a period, you can manage this. But the truth is that's another example of, disparities. That group took a very small gift and ultimately advanced to a multi-million-dollar grant from the NIH. And our team here are one of the leaders. So these projects are pretty cool. Anyone in the New York area may have seen our campaign, because advocacy and empowerment of women is important. And Northwell has put out a multi-platform campaign that really launches a revolution in women's health, that our clinicians and scientists should be able to work together, their work should be funded, but that our women shouldn't accept, dear, it's all in your head, with some issues that are unique just to women. And just as a break, when we get back to gender, for those of you who wonder how, I heard a little bit of talk about work-life balance before. I'm the mother of 3 kids, 1 daughter-in-law, 1 maybe soon-to-be son-in-law, a grand cat, and we'll talk a little bit at the end about work-life, how I think you may want to reframe the way you look at work-life balance. Men and women are different. So we're going to move on now, if I could. I particularly like the one on the right. My husband laughs, like, how many black pair of shoes do you need? And, women are a little more complicated than men. And, those two on your right certainly tell you what differences are. I'm going to talk, and I don't know actually if we should take, I'm going to keep going unless you tell me otherwise. I'm going to pivot
Hey,
to
just keep going. I
going,
mean,
Dave.
you have like, it's 10:25, so I would leave maybe 20 minutes for questions there. I'm sure there'll be a lot of questions. They come fast and furious. So
Perfect.
just keep
Great.
doing what, just keep that in mind.
You got it. Thanks. Clock is on. All right. So I'm going to use women and heart disease as the example of what happens when we do this badly. So I don't know if anyone on the call either read the Isaac Bashevis Singer book or saw the Barbara Streisand movie, right? Yentl had to disguise herself. She was a girl in an Orthodox Jewish community, and the only way that she can study was to disguise herself as a boy. And so Bernadine Healy, as I said, the first female to run the NIH, wrote this in 1991 in the New England Journal. She called it the Yentl syndrome, and that women should not be treated as little men. And when she became head of the NIH, she put into place rules. If you wanted to get funding, you needed to include women. If you wanted to get a drug before the FDA, you needed to study women. And Dr. Healy and Susan Blumenthal, who's still living, Dr. Healy has passed, really brought this to Congress, to the FDA for funding, to be sure that this was a priority. So in the heart world, heart disease remains the #1 killer of women. It has been, forever. And it was always sort of a man's disease. 90% of women have at least one risk factor for heart disease, and 80% of heart attacks and stroke and heart failure are preventable. And when we started looking at this, we realized women did worse after their first heart attack. Women did worse with bypass and stents. Women did worse with heart failure. And so for something that historically we thought of as a man's disease, women were doing pretty badly and being ignored. So this quick slide shows the mortality rates. And I'll fess up, I graduated med school in 1985. I told you I'm 59 and a 6-year med. And that was exactly the year that the mortality trends crossed. And you could see the blue curve is, a down sloping ski slope, pretty a good decrease in mortality. And the 80s and 90s were the years of CPR and stents and improved bypass and pacemakers. But look what happened to the women in red. Not only didn't they have advantages from this, explosion of technology and science, but they actually did worse. So that by the year 2000, the gap was as big as it's ever been. And around that time, we realized that this is a disaster. Women are doing worse and worse. Men are doing better and better. This is certainly not a man's disease. And we have to redo this. And so what we started, and it had to be multi-pronged, it was increasing awareness. The media became a huge partner, TV commercials, women's magazines. We demanded more funding from the Heart Association, from the NIH. We insisted on gender and sex focused opportunities to understand why is stroke different, why is atrial fibrillation, a rhythm different. And we had a huge impact. Unfortunately, you're seeing trends for both men and women get worse over time, and separate story. One of the interesting things is that we discovered that women's arteries in the heart, coronary arteries that feed the heart muscle, and when blocked can cause heart attacks. Even the arteries can be different, and that the actual anatomy of some women, particularly women in their 40s and 50s, when they have heart attacks, is actually different than men. Women develop heart disease a little later, but there are some risk factors that are not only more prevalent, but are more potent. So a diabetic woman is 3 to, sometimes it's been quoted at 10 times at higher risk for heart attack and stroke than a diabetic man. And for some reason, a Latina, a Hispanic woman, is at even higher risk as a diabetic than a Caucasian, Black, or Spanish, a Hispanic man. Women are at risk for certain conditions that are unique to them. There are some risk factors that are unique to women, and we've been focusing on them more importantly. This came out in 2019 from a colleague of mine at New York Presbyterian, and found that there are some risk factors that are actually unique for women. So pregnancy-related issues, the heart is a lady part, is what a colleague of mine jokes. And that anything that goes on related to when you get your first period, when you go through menopause, when you have children, whether you have issues during pregnancy, even not losing the weight after a pregnancy, all put women at higher risk for cardiovascular disease. So gynecologists and internists and cardiologists now work together. All of those conditions I mentioned, lupus, rheumatoid arthritis, all of those things put women at higher risk for heart disease than men with similar conditions. So now we take histories different. When I see a new woman in the office, I particularly get a giggle when I ask a 75-year-old about her pregnancies. Her kids are older than me, but she still looks at me like, why? And it's because anything that happens in that pregnancy can portend an increased risk as we grow. This has been data that came out that there are some risk factors that are more prevalent in women, but also more potent. Physical inactivity, obesity, depression is highly more prevalent in women than in men. And we know that that has an impact on heart disease, cardiovascular diseases of all kinds. So again, when we ask the questions, this is one of the important reasons that that red line started looking a little bit more like the blue line. We even discovered that women present with heart attacks differently than men. That is a picture of what we call the Hollywood heart attack. It's usually an old white man or an OWM, as we joke. Sometimes he's got a cigarette, a pastrami sandwich. He's clutching his chest. He's stressed. And that's what we envision a heart attack to be. Women are more likely to not use the word chest pain when they come to an emergency room. They don't feel well. They're tired. They're a little more breathless. I've had women present with toothaches that have gone from dentist to dentist, only for us to discover that they've got ischemic heart disease. So even the way we envision a heart attack to happen is something that put women sort of in a bad place when it came to early diagnosis, early treatment, and prevention options. The AHA put out a pretty interesting study that women are much less likely to call for an ambulance if they think they're having a heart attack if it's for themselves, because women just don't think of themselves as being at risk for heart disease. They would always call if they were the bystander to a man standing next to them. So all of this stuff resulted in unique sex and gender specific guidelines for us. And there is a whole body of work now: prevention of heart disease in women, prevention of stroke in women, how we do stress tests in women, how we treat heart attacks in women, how we treat other interventional procedures done by surgeons or interventional cardiologists. So we now know that we treat women differently because the anatomy, physiology, presentation, even the way they manage medications are different. And this is what we did in women's heart disease. So why would that be different in depression, in gallbladder disease, in lung cancer? But here, this is sort of the quintessential why women's health matters, because the lives lost were pretty dramatic, and the disparity between men and women's death rates what was shocking and unacceptable to all of us. When you scan the brains of men and women with depression with MRIs, the scans look different. Lung cancer, as I said, the likelihood of dying in a non-smoker is significantly higher in women. Women's liver diseases are completely different. So this is what women's health is. And heart, for me, just sort of solidified my passion. Advocacy and education is important. My husband is a dermatologist, by the way, so he actually sent me this slide. Advocacy is really important, as is education. Along with my colleague, Dr. Jennifer Meares, Jen is the Chief Diversity Officer for Northwell. We've written books, Heart Smart for Women. The new edition will come out in the fall. We did it in English and Spanish. We are also the executive producers of a documentary. It's embarrassing to say that in front of Dr. Langer, who, if you haven't seen it, it's fabulous. But Misdiagnosed is an interesting film that we made with an Emmy Award filmmaker that actually launched at a very important film festival in California the week that the country closed down for COVID. So, part of my passion is being out there, educating community and advocating as well. I just want to talk a little bit about, I'm going to turn these slides off if I could. see. Stop sharing. Little
Should be at the
helps.
bottom of your screen where it's like a little X at the bottom over the share screen thing. It's the same place the share screen was.
Bottom middle, yeah. You just have to stop sharing.
Yeah, I have just gotten stop sharing. Got it. Okay, we're back. I wanted to just end with a little bit about, you know, Dr. Langer asked about mistakes, and when I was a fellow, I remember looking at chairmen of departments and section heads and others, and I thought, you know, wow, how did they learn to do that stuff, right? There's a budget I figure they had to do. They had to select fellows. They built cath labs and cardiac operating rooms. And it was clear to me that in those days, if you were the best doctor, if your grants got you published, if you were on national committees, you were elevated to section heads and chairmen. But the truth of the matter is we've now learned that becoming a chairman, a section head, having a leadership role really is a unique skill set. And when I learned that, I started reading outside of, you know, how to stay up to date with echoes. And what I started reading were books about leadership skills, how women lead, how men lead, how you learn. So I've never done formal training in an MBA or a master's in public health, but I was an avid reader learning that these things are important. And what I learned on the road is that these are technical skills that are learnable. And they can be learned by doing additional degrees or studies. And they can also be learned by finding mentors and sponsors. And I'm sure you've heard all of that before. So you know, there is a difference between a mentor and a sponsor. A mentor is somebody who helps you. A mentor is somebody that you may be assigned in college or grad school or medical school or your residency or fellowship. But a sponsor is somebody who advances your career. And over a lifetime, you will need both mentors and sponsors, no matter what you do. A mentor is often assigned in training or someone who you find in your schooling or your training. A sponsor is earned, and a sponsor is somebody for whom there is a bi-directional relationship, that you do something for that sponsor as a junior faculty maybe, and that sponsor puts you up and says, wow, you know, there's a new committee and I think Stacey Rosen would be a good member. When Dean Smith, our founding dean of Zucker, talks about how you get promoted, how you advance your careers, he reminds everyone that you don't go from first year, you know, intern to chairman of the department in a weekend. And that the first thing you may want to do is say yes to the yucky committees. I think Dr. Smith talked about the dog walking committee and the bathroom cleaning committee, and finding the mentors to help you, but having the sponsors who truly advance your career by putting your name forward, by helping you get onto a committee, by supporting your research initiative. And again, in that relationship, you need to do right by that person, because that is truly bi-directional. And I can tell you, having been sponsored, mentored, and been a sponsor and a mentor, they're all very inspiring roles. I have lucked into some extraordinary sponsors before I knew what that was, honestly, and have had some extraordinary mentors and still do, you know, honestly. But I think that, and I am happy to send some of the reading material that I have. Somehow this slide is frozen, and I do have some things. How Remarkable Women Lead is a marvelous book. Adam Grant and Sheryl Sandberg did a series on how women work that is exceptional. Adam Grant, who's a Wharton professor, is an extraordinary writer when it comes to this. Better Health for Good is an institute at Penn that has free lectures on how women advocate. So there's all kinds of material out there that, you know, I took advantage of. And women, honestly, are less likely to have a sponsor than men. And historically, maybe sponsorship happened on the golf course or at a bar, and, you know, maybe women drove home and took care of 3 children. But the truth is, all of that is changing. And we spend a lot of time in my field wondering how we get more women into cardiology. Women graduate 50% of our med school class. Practicing women cardiologists are 14%. Our fellows are only 20%. One of the persons who is focused on this the most is the male chairman of medicine at Stanford University. Bob Harrington is the triple threat: physician, scientist, educator, and he knows that Stanford, one of the best programs in the country, is going to have problems over time recruiting the best if women don't want to be in the field. So I'm sure Dr. Langer's world, my world, we focus a lot on how we make women feel comfortable in my profession and how we are sure to make women in cardiology something that ultimately hits a 50-50. And defining what's important to you and defining what's not important to you. And I will just tell you a quick story. My daughter is a PGY3. I couldn't get her to go into cardiology. My husband or dad couldn't get her to go into dermatology. She's an ophthalmology resident. And her first rotation was in general surgery, Dr. Langer. And she calls me the first day and she says, "Oh, Mom, I love it in there, but the surgeon kept calling me girly." I'm like, oh my God. I'm like, okay, before you freak out, I want you to go to the charge nurse tomorrow and ask what he calls the male medical students. She calls me up that night, laughing her head off. She said, he calls them dude. And she says, well, girly might be a little bit more insulting, but the truth is he simply can't remember our names. And so we had a long talk about what your priorities are, what your values are, what your line in the sand is. And she realized that to assume that he was being insulting to a female medical student wasn't the right thing. So over my career, I didn't think being called the girl fellow was particularly insulting. But when an attending wouldn't let me put sheaths in a procedure because I was female, that was my, line in the sand. And then finally, one quick, I know we're at 10:41. Stuart Friedman, who is also a professor at Penn. I am not a Penn graduate, but like the rest of my entire family is. I know Dr. Langer, you are as well. And Stu Friedman is a professor at I think both in arts and sciences and at Wharton, and it changed the term work-life balance to work-life integration. So I am working from home today till my lights went out. So now I'm sitting with you in my office. So if I was home and running a load of laundry, because that's my home chore, is that Stacey Rosen at home or is that Stacey Rosen at work? You're the same person. Your priorities, your concerns, your strategy in life, the way you are is the same at work life. And when you use the term balance, it means that it's a zero-sum game, right? Something goes up, something goes down. So Stu Friedman actually pivoted to work-life integration, because you are you wherever you are, and you are you whether you've got a white coat on or, holding a baby or cooking or doing whatever else, brings you passion outside of your prevention. And he's actually Stu's done a whole bunch of interesting work with us here at Northwell. He actually changed it just recently to work-life harmony. And we had a whole debate about that, because if your aim is to define your true self and be that, and be a little bit less hard on yourself, then you can do what you like. And I can tell you, there have been days that I have screwed up as a doctor, a wife, a mother, a girlfriend. You pick yourself up, you learn your lessons, and to do your best you can. So I think I should stop because I could go on forever. I apologize. And I'm happy to, take any questions and share the slides and anything you'd like. David, thank you.
That was great. Ash, you can pick off questions. Just want to make a couple of comments. Firstly, I think that what we admittedly, I'm not sure if we would have, I bet have eventually invited you, but just from our study last year of this group, it's just such a huge super majority of women. And so it doesn't mean we're teaching to the audience, but it's also reflective of this sort of sea change in the types of people that are going into healthcare and medicine in particular. And I think we, as whether you're male or female, have to recognize that and agree that we have to make accommodations. Men have to do it too. I mean, we think that we have to learn about this whole, cannot have a blind eye or this kind of unconscious bias to what women think. Your story about your daughter is a perfect example. I do think that there has that my also bias is that women have to recognize there's this change is going on, and that it's not all negative if somebody's kind of in the old school. And oftentimes, I took this course on dialectical behavioral therapy, and there's this whole thing about your three kinds of minds. You have your reasonable mind, you have your emotional mind, and your wise mind. And I think that a lot of times we approach these problems very emotionally, like we react, we think we're being wronged, and men too. I mean, and I think even with this whole Me Too movement, it's hard to always be perfect. And so you can say the wrong thing, you can imply the wrong thing, but the majority of the time it's not as deep. There's maybe an unconscious bias, unquestionably, but you have to, and the reasonable mind is always like, oh, we can work this out, or this isn't such a bad, but sometimes it is bad. And so the wise mind looks at both sides, recognize that there's truth on either side. And I think that for women who are getting into healthcare now, you have to recognize that it is a male-dominated field, most of them. But we know there has to be change. The only way we're going to move that 14% number, whether it's cardiology, neurosurgery is about the same, about 14%. It's way less than that, for example, in cardiothoracic surgery, is for women to understand that they've got to recognize that they're making a change and be a wise mind when they're dealing with men who may not be that way. And that's really tough. And as far as the work-life balance go, I always tell people, I don't think there is such a thing. It's like if you have a great spouse and you love your job, or a great significant other, it's all one continuous thing. You need to be fulfilled at home and fulfilled at work. And the good partner recognizes the value that you bring to your work, and the people at work recognize the value that your family has. And it's not always well balanced. Sometimes it's really unbalanced, but you obviously love what you do, and that's an important thing to have. If you hate your job and you never have balance. So I think I think it's especially in medicine, which is really a lifestyle rather than a job. You have to have that, and if you don't, so when you go to pick, like I always say, your most important choice is not what going to medical school. It's what kind of doctor you want to be, and who you're working with, and who your significant other is. Those are things that impact your career more than just going to medical school. And so I enjoyed what you the perspective that you have, and I think you're really representative of the best of what women can accomplish. It's great to have you here. So I'll turn it over to Ashley to pick off some questions here.
I'm just going to let the group in on a little secret. So when I became the chief of cardiology, I was 37. I had 3 young children at home, a husband working, live-in help coming and going. At the time, a chairman who we worked 20 hours a day. We built practices. And after about 18 months of that, I realized this is non-sustainable for me. So, I had a conversation with my husband. I said, I'm gonna step down. I'm gonna take a sabbatical. We're gonna figure this out. So Sunday night pizza dinner in my house. My twins were about 8. My little one was 2.5, and I thought I was going to give them the biggest gift ever. And I announced to them like a queen that I was quitting work. And the 2 older kids started yelling at me. We don't want you home. You'll be one of those irritating mothers. You'll be miserable. My husband's in the kitchen laughing his pants off. And I always look back at that story that, you have to have a sense of humor. You have to love what you do. And I tell women when they think about fields like ours, David, pick what you love and figure the rest out. You can work part-time in cardiology. You could not be on the professor track. You could not run a department. But the idea of doing something that I don't love, that's torture.
I think the pressure on women is much greater than men. There's less expected of us, I think, and on top of that, women have created this problem for themselves in a way. Yep. And I think your kind of reaction, like I'm doing all these things, like the soup, the cape in the closet, it's not your fault that women have to are the ones having the babies, and that there's a maternal instinct, and that there's a societal kind of acceptance of certain things that men do and don't do. And that's changed slowly, to have a perfect, for men to be the homemaker and to do those things. It happens. It's not as common. And so women feel this tremendous, my wife's a cardiac anesthesiologist. She went through the same thing. She decided to stop. She was working, 6 in the morning till 7 at night. And when my daughters, we have twins, when they grew up, she wanted to go to their games. She decided to back off and she was a pediatric anesthesiologist. It's just, you know, it was hard for her,
Yeah.
and she's given up a lot for me, and she's made, you know, sacrifices. And in the end, it's a team, you know, and I think if you have a significant other, that's where the balance comes in, is balancing each other.
Yep.
And whether it's a woman or a man, it's really the same thing. And when you have kids, then you have to decide, you know, how to give care and what the balance is with that.
Yeah. It's
But
a
I
whole
think if
other
you're
job. You can't make believe it's not, right? It's a
your
whole
kids
nother-
your kids recognize how valuable your career was to you, and that's great. So there's a question here about when, you know, when you have your children. Obviously that's changed a lot with residency and work hour requirements. When we were residents, it was just impossible to have a baby as a resident. Now you really can. Maybe you can comment on that transition. I think that's one of the reasons why healthcare is, or being an MD or a DO for that matter, has become more accessible to women.
Yeah, no, you're totally right. So my husband and I were, my sister-in-law, his sister is actually a senior physician at Northwell as well. We were house staff at Montefiore. She thought we would make a nice pair, and she put us as an intern resident team in a coronary care unit. Mark really hated cardiology, did internal medicine, then derm. But so we were married as residents, and he did a second residency in dermatology and melanoma research, and I was in my cardiology fellowship. And my last extra year of cardiology fellowship, there was no radiation exposure. So we thought that would be the perfect time to start a family. And, you know, I don't know what that old Jewish expression is, man plans and God laughs. So we thought this was the perfect time. And I conceived natural twins. And when I found out, I was bawling, crying in the fellows room. My husband thought it was the coolest thing, but this wasn't part of the plan. One child at a time. I had taken a job, and I can't imagine having had children in residency or fellowship. As you said, David, quite aptly, you know, it was 24 on, 24 off. Cards fellows at Cornell did full weekends. We were in all, you know, it was unimaginable. But when I ran our cardiology fellowship at North Shore and LIJ, I would say the majority of married women had kids as fellows. And ironically, the ACGME doesn't give time. That's the guiding body that oversees the training that we all do. And we're working on making it easier for men and women who choose to have a family to, you know, get some time at home. And but it was unimaginable to otherwise have had kids in training.
Now it's very imaginable.
Yeah, we you know, we see it all the time. There are babies at our fellows graduation. It's pretty fun.
Ash, you want to pick it up?
Yeah, sure. That's exciting. I think that it's really good to hear that, like, and see women just like kicking butt and taking names like in the field of medicine, because I don't know, I always do, like, the family thing is in the back of my head. I'm like, how do you possibly do it? But I know it can be done. Like, it happens, you do it. But Dr. Rosen, this is a little bit more on like research, and now having like female subjects, animal subjects, and also like human subjects. So the first thing is establishing like there may be a difference between like men and women in some area of the research, but how do you go about like localizing where that difference comes from, and also like avoiding there being like stigma and that kind of being turned against women in some way? Like, I feel like there's a fear with certain research that like because of like the findings, it'll be used like against women. And so if you could comment on that, I would really appreciate that.
Sure, thanks, Ashley. That's a neat question. So when I mentioned the aspirin study with the Katzes, so the Harvard Health Study came out in the 80s and 90s. It was several tens of thousands of male doctors at Harvard University, Harvard Medical School, and they found that, you know, baby aspirin, you know, controlled group, one got aspirin, one half didn't. Those who got aspirin were less likely to have a heart attack or stroke. Okay, so we assumed that that was women. It wasn't until Harvard and an NIH-funded study called the Harvard Nurses Study, you could all laugh at the irony of that, found that it studied only women and seriously replicated the study and did not find the same outcome. So for science, it means that simple questions, we have a new drug in heart failure, right? We should test it on men and women, right? And we should test it in the number that is equal to the prevalence of the disease in the community. So of all heart failure patients, about 65% are women. So any heart failure trial, drug, prevention, device use should have 65% women in it. And that means we have to uniquely recruit that. And then we have to present the data independent. The drug showed 10% less hospitalization in the first year. And that was found in men and women, or that was only found in women. So that maybe I won't give my men that drug, right? Because if we reported it together. So that's what we talk about. It is looking at the gender and sex of the people or animals being studied and seeing if there's a difference in outcome and making sure your hypothesis includes that from the get-go. Does that make sense?
Yeah, 100%. That does make sense. It's just like so crazy for me to wrap my head around still that like it hasn't always been this way. Like that to me is just like, how?
So in the cardiology world, just last year, Circulation is our best, most highest impact journal. They looked at the last 10 years of studies, and in coronary artery disease, what causes heart attacks, 10 years worth of NIH and American Heart Association funded trials had 32% women in it. So, when somebody thinks, wow, we're not done with this. Yeah, we are not done with this.
The other thing I found was interesting in reading a lot of this stuff was that when women come to the ER with chest pain or cardiac sort of symptoms of heart disease, heart attack, they're not taken as seriously.
Yep.
And not only by men, by women too. That there's
absolutely. Yep.
There's like they think they're hysterical, or they think that they're emotional, or they're connected. And that's why women's outcomes aren't as good for MIs. But I don't know if that's changing. Has that started to change? Have we seen any change in that?
Yeah, not fast enough, David, quite honestly. There's still, even our Northwell cardiac team has put out some stuff about, door to balloon time and, each of these metrics that we have to do. The faster you recognize a heart attack and treat it, the better off you will be. And what's cool about that is that we work with our emergency departments, we work with our EMTs, but we also work with women, because I tell my patients, when you get to an ER, you scream on the top of your lungs that you're having a heart attack. Don't say, oh, a little shoulder pain, or, take that bleeding man first. Scream at the top of your lungs. And sort of working it in both ways. We're better, but not really so good yet.
Just before you go on, there's a question here from Jocelyn Montero. This stuff drives me crazy a little bit about the RNA vaccine increasing cardiovascular disease and affecting women. First of all, these are not the RNA vaccines. The AstraZeneca is not an RNA vaccine. And these are tiny, tiny little, these are so overblown that it's just not, you guys, 1,100 people on this call, please go to your families, talk to your friends. These are tiny, it's like we'd think shark attacks we're having every day. It's that kind of thing, or that planes are crashing all the time. The press is looking for these things. There's no question there are going to be some side effects, but the RNA vaccines were not responsible for the blood clots in Europe that were picked up primarily in Denmark. That was the AstraZeneca vaccine, which is not an RNA vaccine. The mRNA vaccines are remarkably safe, and some of the reactions have been immunological that have been mild. There have been some bad reactions, but not. There are literally 100 million people have gotten these things, 200 million, and we've had like 10 reactions. So just keep that in mind. I'm sorry I saw that question. I just had to say something.
Thank you for clarifying that.
And no issues on infertility, and no issues on pregnant women need more than men. Go to the data.
Cuckoo for Cocoa Puffs. QAnon level. It's QAnon level stuff.
Dr. Langer, do you mind if I throw in another question? Just because you said something about how like it's not just like men that might not take like women as seriously, like it's women too. And I was wondering if you could comment, Dr. Rosen, on how you think we can like better build that community between women, because I've heard it's become like every woman for themselves, and like that's not like helpful for anyone. And so like what do you think we can do to kind of like band together? I mean, men and women, but also like women in particular.
Yeah, no, that's a really fair question. And I and my two daughters wear a necklace that has a gold queen bee on it. And, I think there's a lot of, QAnon level stuff about women being, excuse me, bitchy at work and worse to other women. And the truth of the matter is, I've not seen that. I really haven't. I have had equally bad relationships with men leaders and women leaders. But what I think is interesting in medical school, there's the American Medical Women's Association, which we have at Zucker, and I am one of the faculty advisors. In the American Heart Association, we have a women in cardiology group, and that we support each other, we support research, we advocate. I've got a WhatsApp auto raft of women from all over the world, female cardiologists that share everything. I send patients to them. I think that there are the partners out there. My heart sings when I know that Bob Harrington, again, the chairman of medicine at Stanford, is the biggest proponent for women in cardiology. He is the father of either 4 or 5 girls, women, actually 2. I think, as we said, don't make assumptions, have a sense of humor, define what's important. Like I said, being called the girl fellow, whatever. But when somebody wasn't going to teach me to put sheets in because they didn't think I had the skills, despite having been a resident of a city hospital where it's all we did was, procedures, that was a line that I couldn't tolerate because I wasn't going to learn stuff, I think you find your squad over time, and it's likely to include men and women. My brother, who's not a doctor, is one of the best, he for she's, and one of my favorite cheerleaders, honestly, beside my husband.
Well, that was just great. We could talk forever about this, such an interesting topic. We'll try to have you back next. We'll be doing brain terms forever, I think. So
Awesome.
your contribution was huge, and thank you for taking the time out of your busy day and your family to spend it with this team. So appreciate it.